Welcome everybody to this OrthoEvidence special on a new webinar series on injectable therapies for knee osteoarthritis, new guidelines, new directions. I'll be presenting along with my co-host, Dr. Tom Wood, injectables for knee osteoarthritis. We're going to be looking at some high-yield papers that have been published over the past few years and going through these articles, journal club style, and having a discussion about these articles. And so thank you everybody for joining us. Just a reminder that this event is recorded and we welcome you to turn on your video, but please stay muted unless you want to ask a question. To ask questions, please hold questions until the discussion slide arises and then raise your hand on the Zoom app, or you can ask questions in the chat box so that we can see them, and then we'll field them and discuss. As a reminder, the full recording will actually be uploaded to OrthoEvidence after the event. So with that, we'll get started. We'll be going through 8 ACE reports covering a variety of intra-articular options. I'll just go through them here. So the first one will be on knee osteoarthritis, the therapeutic trajectory of corticosteroids and hyaluronic acid. The second paper will be a paper on the safety of intra-articular hyaluronic acid for knee osteoarthritis, a meta-analysis. The third ACE report will be on reduced pain with hyaluronic acid combined with PRP versus PRP injections at 6 months for KneeOA. The fourth paper will be on the efficacy of intra-articular hyaluronic acid injections for knee osteoarthritis by molecular weight. The fifth paper will be on leukocyte-rich versus leukocyte-poor PRP for knee osteoarthritis. The sixth paper will be on autologous bone marrow-derived chondrocytes for patients with knee osteoarthritis. The seventh paper will be on PRP injections improving pain, function, and quality of life versus hyaluronic acid injections for knee osteoarthritis. And the final paper will be on platelet-rich plasma is superior to hyaluronic acid for symptomatic knee pain at 6 months and 12 months for knee osteoarthritis. So we'll hopefully get through these 8 ACE reports over the next 50 minutes or so. And before we begin, I wanted to just highlight this slide, which is sort of your take-home points for this event tonight, which really is based on OrthoEvidence's internal network meta-analysis tool. And so OrthoEvidence has analyzed all available randomized controlled trials across all injectable therapeutics and organize them on this forest plot here based on efficacy. And so you can see here, this is the minimal important difference or what a patient would perceive to be the minimal amount that a treatment would be considered useful for them, or that they would want to proceed with that treatment. And so you can see here, corticosteroids has a effect which is just on the minimal important difference, and it's past the line of no difference. So there is an effect of corticosteroids. Low molecular weight formulations of hyaluronic acid, while they may be statistically significant, they may not be clinically significant, whereas the higher molecular weight formulations get closer to that minimal important difference. There are also hyaluronic acid formulations with gel which cross the line of no difference. And there are combination injections, which we'll also be talking about today, of corticosteroids with hyaluronic acid, which pass not only statistically significant, but also the minimal important difference. Platelet-rich plasma, when you look at the entirety of the evidence, while the pooled effect estimate does favor the treatment itself, the confidence intervals cross the line of no effect. And so our overall confidence in the efficacy of PRP is still unclear. There are extended release formulations of corticosteroids. Mesenchymal stem cells are really all over the map. Insufficient data on combinations of mesenchymal stem cells with hyaluronic acid. platelet-rich plasma with hyaluronic acid. Again, pooled effect estimate here, but wide confidence intervals. We're not sure whether the true estimate of effect favors a placebo or is quite strongly favoring the treatment. And mesenchymal stem cells combined with PRP, there's insufficient data on. So this is sort of a take-home slide of the entirety of the data. And with that, we're going to get started looking at the first paper. So this is a ACE report, knee osteoarthritis, the therapeutic trajectory of corticosteroids and hyaluronic acid. It was published in Arthritis Rheumatology, 2009, by Dr. Banaru et al. And so the question they asked was, how do hyaluronic acid and corticosteroid injections compare in symptomatic relief of knee arthritis? And this is a question that we probably all have had in our clinics when you're presenting the available options to a patient, and a patient will ask, well, doc, which one should I go with? How do these two options compare? One of them may be more expensive than another. Is it worth the additional cost? And so this was a systematic review and meta-analysis of 7 randomized controlled trials comparing conservative treatment methods of intra-articular hyaluronic acid injections and corticosteroid injections. And they looked at pain scores at 2 weeks, 4 weeks, 8 weeks, 12 weeks, and 26 weeks post-injection. At early follow-up at 2 weeks, treatment with corticosteroid injections resulted in lower pain in comparison to hyaluronic acid injections. From 4 to 8 weeks, treatments demonstrated similar efficacy, and at 12 weeks and 26 weeks, hyaluronic acid injections actually demonstrated significantly lower pain scores compared to corticosteroid injections. And so some details on the actual process of the study. So they searched Medline, Embase, Sinhal, Biosis, and Cochrane trial registry. And so this really is a comprehensive search whenever more than 3 databases are searched. They searched from 1990 to 2009. They used appropriate search terms, and they really looked for only randomized controlled trials in patients with knee arthritis comparing HA versus corticosteroids, and they looked at various pain and functional outcome subscales. And so the important findings at 2 weeks, pooled pain results from 5 studies really favored corticosteroids, whereas at 4 weeks, there was no significant difference. And from 8 weeks to 26 weeks, the trend really was more towards hyaluronic acid. And so you can see here in the forest plots, the overall pooled effect estimate initially at 2 weeks favored corticosteroids. But as we progress in time at the 4-week mark, there's no significant difference between the two, whereas at the 12-week mark, very strongly favoring hyaluronic acid. And again, sustained at the 26-week mark, the pooled effect estimate really favoring hyaluronic acid. So I think this is a very useful information for when you're counseling your patients about the trajectory of the pain relief they're going to experience. And this is just presented another way, again, initially favoring corticosteroids, and as time progresses, slowly moving towards favoring the hyaluronic acid. And so I think as a discussion point here, we'll ask this question: how do you counsel patients regarding HA trajectory? And I think actually we have a poll here that we want to get information from the audience. Do you routinely counsel your patients about local reactions when giving hyaluronic acid?
I can just chime in while this poll is happening. It's interesting. I think a lot of practitioners, orthopedic surgeons, now use combination products for this exact reason. They want the steroid up front to decrease inflammation and allow the HA to kind of settle in. And it's encouraging that HA has pretty sustained effects for 12 to 26 weeks. So pretty interesting study.
Yeah, I agree, Tom. I usually also try to combine my injections because of this. I want that initial anti-inflammatory effect from the steroid, and then I can counsel the patients that they're looking at 6 months or so that they're going to notice some improvements from the hyaluronic acid. Be interested from the audience as well, regarding counseling patients on the trajectory.
Yeah, so 74% of people who filled the poll out said that they routinely counsel patients on local reactions. I also routinely, I get worried when I do HA injections in isolation, and I really make an emphasis that the first 3 days, I want my patients to really ice their knee, take NSAIDs, take it easy, no kind of high impact activities. Certainly with a combination steroid, I still counsel them similarly, but I feel like in isolation, HA injections have a greater propensity to have patients call the office saying, in 48 hours, their knee is, tight, they can't move it, etc.
All right. We'll share these results in a bit. Okay, let's move on to the next report here. So this is report number 2, the safety of intra-articular hyaluronic acid for knee osteoarthritis, a meta-analysis. Again, this is published recently, 2021. And so the question that was asked was, in patients with knee osteoarthritis, how does intra-articular hyaluronic acid compare to placebo saline injections with respect to adverse events? So we're really getting at actually the question that we polled about how does hyaluronic acid compare to placebo. And so this was a meta-analysis of 8,000 patients looking at randomized control trials only for those undergoing intra-articular hyaluronic acid injections compared to placebo. There are about 4,000 patients in each group, and they looked at the incidence of adverse events. And so what were their overall findings? That there was no significant difference in the overall rate of adverse events between hyaluronic acid and placebo injection groups. There was no difference in the incidence of serious adverse events or adverse events leading to study withdrawal, but the hyaluronic acid group did demonstrate a significantly higher incidence of local adverse events. And so here, if you look here at the overall pooled effect estimates, this is the incidence of adverse events at final follow-up. No significant difference between groups. Incidence of serious adverse events, the pooled effect estimate crosses the line of no difference, so we can't really say there was a statistical difference. Again, incidence of withdrawal due to adverse events, no statistical difference, but local adverse events, again, normal saline is favored because there's less risk of having a local reaction. And so the poll here that we are sharing is really showed that 74% of our respondents here do counsel patients about local reactions. Tom, I'll throw this out to you. How do you manage local reactions in practice?
Yeah, so I think the really severe 1 or 2%, I think is described in the literature as the extreme synovitis. I think that's quite rare, but quite debilitating. And usually patients in that scenario present until they emerge, and then it's really a matter of taking an anti-inflammatory, icing it. I have done in that scenario an acute injection of steroid after obviously ruling out a infection. But that type of experience has really made me use more combination injections with steroid and HA together, and then just being really diligent about explaining the first 3 days of an HA injection. And really, it's a foreign substance. Your body reacts to it, and that usually manifests as warmth, tightness, swelling. So icing it, using an NSAID has made a big difference.
Yeah, I do something very similar. I preemptively let patients know that the next couple of days the knee can be swollen, it can be sore, and that's normal. To be judicious in their use of ice, and go easy on it. Some patients really try to get back to activity very quickly. I try to tell them to avoid running or jogging over the first couple of days at least, to let things sort of settle down before they get back into their activities. Okay. Let's move on to the next one. Okay, so this is the third ACE report. All right. Reduced pain with HA combined with PRP versus PRP injections at 6 months for knee osteoarthritis. And so this is comparing the efficacy of intra-articular single cross-linked hyaluron and PRP versus PRP alone for treating knee osteoarthritis, published in 2021. And so really this is looking at the combination injections, which are becoming more and more popular recently. And so what question did they ask? Well, they looked at in patients suffering from symptomatic knee osteoarthritis, how does a single injection of cross-linked hyaluron combined with a single injection of PRP compare with a single injection of PRP alone with respect to pain at 6-month follow-up? And so looking at the study in a little bit more detail, they looked at 85 patients. These were patients who were aged 20 to 75. They were diagnosed with symptomatic knee osteoarthritis for 6 months or longer, confirmed by radiographic evidence. And they included patients who reported a minimum pain of 30 millimeters on a 100 millimeter VAS scale, which was taken during walking. And so they had two groups, a hyaluronic acid with PRP group, which had 43 patients. Mean age was 60, 53% were male, and patients received 2 intra-articular injections. 1 injection of cross-linked hyaluronic acid, which was 3 mils, followed by 1 injection of PRP, which was also 3 mils, conducted by the same physician. Leukocyte poor PRP was utilized for this study. They compared this to a PRP only group, which had 42 patients, a mean age of 58, so very similar, mean a BMI of 24, and 43% were male. Patients received a single intra-articular PRP injection, 3 milliliters, conducted by the same physician under aseptic techniques, and this was also leukocyte poor PRP. They looked at VAS scores, WOMAC scores, WOMAC stiffness, WOMAC function, a single leg stance, VAS satisfaction, and the incidence of knee swelling and pain, and the incidence of allergic reactions, or any serious adverse events, any incidence of discontinuation due to an adverse event, and WOMAC index. And the time points they looked at were baseline, 1 month, 3 months, 6 months. They looked at the range of events and final follow-up. And so what was their important findings? Well, they found that secondary outcomes, including WOMAC function, WOMAC total score, Laquesne index, SLS, and patient satisfaction, were not statistically significantly different between the two groups at 1, 3, and 6 months follow-up. There was no allergic reactions, pseudosepsis, or serious adverse events in both groups. In addition, 11.9% and 13.9% in the single injection, combined injection groups respectively had knee swelling and pain right after the injections were administered. So very similar. So these are the scores presented graphically. You can see here the hyaluronic acid and PRP group in comparison to the PRP group alone. The visual analog score for pain at 1 month actually favored PRP alone. And at 3 months, again, still favored PRP alone. And at 6 months is when you get the benefit from the combination injections, the hyaluronic acid and the PRP, where the overall VAS score is lower at 6 months. This is looking at the WOMAC score. Again, lower is better, initially favoring platelet-rich plasma alone at 1 month. At 3 months, again, favoring PRP alone. And it's at the 6-month mark where they're actually kind of similar. So no real difference on the WOMAC pain score. What about stiffness? Lower is better here. WOMAC stiffness at 1 month, favoring PRP alone. WOMAC stiffness at 3 months, again, favoring PRP alone. And WOMAC stiffness at 6 months, no real difference between groups. Overall, these trials were pretty well done. So this is a poll for the audience. And we'll also throw out a question to Dr. Wood here as well. PRP with hyaluronic acid, that can be very pricey. What are your thoughts about that?
Yeah, I agree. I must admit, I have not used PRP and HA together. Very interesting, again, that you see a delayed effect with HA, even in the context with combining it with an anti-inflammatory in the form of PRP. Also interesting, you still get local soft tissue reaction with PRP alone. But from a cost perspective, I know at least in my climate, I think that would be very cost prohibitive. Um, and I've just really resorted to using either PRP alone versus steroid and HA in combination. How about you?
Yeah, I have the exact same thing. That would be very expensive for patients. I think it'd be a tough sell. Now, it certainly is interesting information, though, that as the time progresses, the HA starts kicking in. But that is definitely a challenge, I think, in a patient paid healthcare environment. And we'll just end this poll here and share the results that. Only one person used a combination HA and PRP. The vast majority, 96% of respondents here, have not used these two treatments together.
So Moyne, we just have a question that might be premature because we are getting to this, but preferences about using high molecular weight Durolane Synvisc with a steroid versus a combination product with low molecular weight HA, like for example, Cingal.
Yeah, I think that's a very good question. And we definitely are going to get to it very shortly. But in general, I personally prefer high molecular weight formulations, and I'd be interested to get your thoughts as well.
Yeah, I'm the same. I prefer high molecular weight HA, and I do combine it with a lower dose steroid.
Yeah.
But we will go over that as a separate ACE report too.
Okay, let's move on to the fourth ACE report, and we're getting halfway through. So this is efficacy of intra-articular hyaluronic acid injections for knee osteoarthritis by molecular weight, published in 2022. And the article is titled High Molecular Weight Intra-Articular Hyaluronic Acid for the Treatment of Knee Osteoarthritis, a Network Meta-Analysis. So the principal question that this network meta-analysis asked was, in patients with knee osteoarthritis, how do high molecular weight formulations of intra-articular hyaluronic acid, and they define this as more than 6,000 kilodaltons, compared to low molecular weight formulations, placebo, and other non-surgical FDA-approved treatments with regards to clinical efficacy. So the advantage of a network meta-analysis really is that you can take a bunch of different treatments, even if they're not directly compared, and through various statistical methods, get an idea of how they compare to each other. And so this looked at 14 randomized controlled trials with almost 3,000 patients. And they specifically looked at high molecular formulations of HA versus low molecular formulations of HA. They also looked at corticosteroids and other conventional therapies, and they also compared it to placebo itself. And it's important to remember, whenever you're talking about a comparison to placebo, the actual placebo injection has a significant therapeutic effect that's been shown in other network meta-analysis. So already you're comparing it to something that has an effect. And they looked at a normalized pain scale, and their final follow-up was their time outcome. So this is just a graphical representation of the various trials that they included and the number of trials. So the most of the trials that they include in this network meta-analysis were high molecular weight trials. So what were the most important findings? They found that high molecular weight hyaluronic acid injections were significantly better than intra-articular placebo injections. And the threshold that these formulations actually probably surpassed what the AAOS has deemed to be a minimal important difference. These high molecular weight formulations were found to be superior to all other treatments, but this particular study found these differences were not significant. And there were no other significant differences observed in all other treatment comparisons in this particular network meta-analysis. So you can see here, compared to placebo, this would be the line of no difference. These are various minimal important differences that have been highlighted here. And you can see here that the high molecular weight injection of all of them, the pooled effect estimate really is the most favoring the treatment. Corticosteroids are over here, and low molecular weight formulations, again, are less effective. This is an interesting graph, which looks at absolute efficacy along this side here and comparison to relative efficacy here. So the WOMAC score, as you get higher up, you have a better outcome. And you have here low molecular weight formulations, intra-articular corticosteroids, and high molecular weight formulations being the most efficacious. And here, compared to placebo, as you go along this way, it becomes more efficacious. So the high molecular weight formulations really are in this top right corner, where they have a high absolute efficacy and a high relative efficacy in comparison to a intra-articular placebo injection. So I think based on this research and a lot of research that has come out now, interesting question to ask is there actually a role for low molecular weight hyaluronic acid? And I'd be interested to hear see what the results from this poll are going to be from our listeners. So do you use low molecular weight hyaluronic acid? And I know we kind of talked about this again already, but Tom, is there a role? What is your thoughts?
I pretty much exclusively use high molecular weight just based on some of the existing literature that we presented, and just kind of my sense on the mechanism, how it works. I'd be curious to those that are in this 10% who use it, if there's any other indications to use low molecular weight, or what their thoughts about using it. You can either post in the chat or raise your hand.
Yeah, so the results here, just to share with the audience, 70% do not use low molecular weight formulations, 10% do use it, and actually 20% sometimes use it. So again, that's very interesting. And I'd be interested to see if for anyone reporting yes or sometimes, if you can just enter in the chat, as Dr. Wood suggested, what your indications are for low molecular weight formulations, if anyone wants to share.
The other possibility could be just the way that their clinics, in terms of acquiring HA, they just may have better price points with combinations and combination products, which inherently have low molecular weight, is probably one way that people are using it, perhaps.
Yeah. We
have one question here. When comparing steroid and HA at 6 months, although HA is more favorable, do we know if it met the MID? I think that was based on the first ACE report. That study, I don't think had MIDs.
Yeah.
That study was strictly a head-to-head steroid versus steroid and HA. But we can summarize that in our last slide. We kind of go over the OE network meta-analysis, and that will make that question a little bit more clear.
Yeah, and there is another paper that published in JBJS, comparative efficacies across them, and I do believe that a corticosteroid at 6 months did meet MID on that paper. Let's move on to the next paper. So ACE report number 5, leukocyte-rich versus leukocyte-poor platelet-rich plasma for knee osteoarthritis. There's a lot of talk recently about leukocyte concentrations with PRP and whether poor concentration should be used for knee osteoarthritis versus some companies coming out with a new autologous blood products, which are leukocyte rich, and really promoting the role for leukocyte, raised leukocyte concentrations in osteoarthritis. So this is a double-blind randomized controlled trial published this year in AJSM. So what was the question? In patients with symptomatic knee osteoarthritis, how do 3 weekly intra-articular injections of leukocyte-rich platelet-rich plasma and leukocyte-poor platelet-rich plasma compare with respect to International Knee Documentation Committee scores, as well as clinical outcome scores at 12 months follow-up? And so this trial had 192 patients who had unilateral symptomatic knee osteoarthritis with a history of knee pain and swelling that was unresponsive for at least 2 months of non-operative treatment. They looked at leukocyte-rich PRP and compared it to leukocyte, it should be leukocyte-poor PRP, and they looked at IKDC scores, Tegner activity score, KOOS pain, KOOS symptoms, KOOS ADL, KOOS sport and rec scores, KOOS quality of life, EQ, 5D, VAS scores. And they looked at baseline, 2 months, 6 months, and 12 months. So what did they find? There was actually no significant difference between the 2 groups in terms of KOOS pain, symptoms, activity of daily living, sports recreation, and quality of life subscores at all the time points. And this is the graphical representation, the ACE report here, leukocyte-poor PRP and leukocyte-rich PRP on the left. You can see here that the IKDC scores really very similar between the 2 groups. How about the subjective score of the IKDC at 6 months? No real difference. At 12 months, no real difference. What about function? At 2 months, no difference. Scores were actually identical between groups. At 6 months, essentially identical. At 12 months, no real difference. Quality of life, basically exactly the same between leukocyte-rich and leukocyte-poor. 6 months, similar, and 12 months, again, essentially the same. So I think a couple of things for discussion. One, we'll do a poll. What is your preference for leukocyte concentration with PRP? And another, I think, interesting point, just based on the methodology of this study, is that they did 3 sequential PRP injections, one after another. And I'd be interested, Dr. Wood, in your practice, what's your preference? Do you do multiple PRP injections, or do you just cap it at 1?
Yeah, I was literally going to ask you that question too. It's interesting. I have to say, I don't do sequential injections like that. Depending on the effect, I'll try and do one and hope that it lasts for 6 months. I try not to inject either PRP or HA multiple times in a 6-month period. That said, I'm a little bit more liberal with steroid in isolation as soon as 3 months intervals. But I must say I don't use a sequential PRP approach. How about you?
I agree. I do exactly the same thing. I just do a single injection, but I have begun to question it a little bit. And I know one of the main reasons why I don't is also cost. But there are a few studies that have shown multiple PRP injections are more efficacious than a single injection. But with PRP injections around $500 or more, that is a lot for a patient to take on if they're going to go for 3 sequential injections. So I haven't been incorporating that in my practice, but the data certainly is out there and it is interesting. In terms of this poll here, we can share the results. 25% of respondents are using a high leukocyte concentration PRP, whereas 75% are using a low leukocyte concentration. If anyone is interested in sharing their reasoning or their indications for a high leukocyte concentration in the chat, that'd be very interesting.
Interesting. Only a few people shared their poll. So maybe perhaps PRP is not a mainstay for injectables, and if so, also you can comment in the chat why preference is HA over PRP, perhaps.
All right, we'll move on, and we can come back to that if anyone adds it. The next ACE report is an interesting one in that it's not commonly performed. It's autologous bone marrow derived chondrocytes for patients with knee osteoarthritis. This is published in 2021. And this was looking at patients who are 45 to 70 years of age with knee osteoarthritis. Does a single intra-articular injection of autologous bone marrow-derived chondrocytes improve pain, function, and quality of life versus an NSAID and physical therapy up to 24 months post-treatment? And so looking at this trial in a little bit more detail, they looked at 60 patients who were aged 45 to 70 who had knee osteoarthritis for at least 12 months. They actually injected them with autologous bone marrow-derived chondrocytes. So they took bone marrow-derived cells, expanded them, isolated the chondrocytes, and injected the chondrocytes into the joint. Mean age was 56. Patients received a single intra-articular injection of 5 million autologous bone marrow-derived chondrocytes, and they compared this to anti-inflammatory medication. And so they looked at VAS scores, modified knee society scores, VAS scores at rest, VAS pain on movement, activities of daily living, and assessment of quality of life. And they looked at baseline 3 months, 12 months, and 24 months. And what do they find? They found that VAS pain scores with and without movement, as well as activities of daily living, were significantly in favor of the injection group at all time points. And so you can see here, this is the overall graphical representation. VAS scores, lower is better, favoring bone marrow-derived chondrocytes versus physical therapy and NSAIDs. VAS scores at 12 months, again, favoring the injection. VAS scores at 24 months, favoring the injection. What about the modified knee society scores? Higher scores are better, favoring the injection at 12 months, and favoring the injection 24 months. Quality of life, higher is better, favoring the injection at 3 months, favoring the injection at 12 months, and favoring the injection 24 months. So certainly an interesting trial with a relatively novel technique. And I'd be interested to hear about the audience's experiences with stem cells in general. And I think one thing that is certainly quite interesting about this study is just the fact that the injection group did better than the non-injection group. And so it may not necessarily be what is injected, but just the fact that the injection itself was performed. And I'd be interested in your thoughts as well, Doctor. What about that?
Yeah, I would have to agree. In terms of a pseudo placebo effect, and also if patients, especially in the US, are paying for these injectables, buying into the treatment could have that effect. With a small study, 60 patients, I'm a bit skeptical about this kind of broad effect compared to NSAIDs and physical therapy, which are grade A evidence treatments for OA. In Canada, we're a bit limited, obviously, from a regulatory point of view. Most of us have never been or had experience with stem cells. And I'd say the last thing, from a mechanism point of view, it's hard to imagine how a stem cell that's being injected will overcome or change, a relative mechanical, problem that generates inflammation, right? Unless it was somehow regulating inflammation, I would have a hard time believing how a stem cell injected into a knee would have benefit.
Yeah, I agree. And interestingly, about 35% of individuals responded to this, and 100%, nobody has actually injected mesenchymal stem cells. So probably related to our population here in our location. Okay, let's move on to the 7th ACE report. PRP injections improve pain, function, quality of life versus hyaluronic injections for knee osteoarthritis. So last 2 ACE reports really are looking a little bit more at platelet-rich plasma. This was a meta-analysis of 26 randomized control trials published in Arthroscopy in 2021, looking at PRP versus HA. And so what question did they ask? They said, in patients presented with knee osteoarthritis, how does platelet-rich plasma injections compare to hyaluronic acid injections with regards to pain, function, quality of life, satisfaction, and adverse event outcomes? And they looked at up to 12 months post-injection, really. And so this was a very large meta-analysis, more than 2,400 patients. PRP group had 1,241 patients. The hyaluronic acid group had 1,189 patients. They looked at adverse events, WOMAC index, WOMAC pain, WOMAC stiffness, function, VAS scores, quality of life scores, IKDC scores, Tegner scores, Coos pain scores, and patient satisfaction. They looked at a variety of time points for follow-up. What were the important findings? The results demonstrate that pooled WOMAC pain and stiffness scores and pooled IKDC scores were statistically significant in favor of PRP compared to HA at 6 months and 12 months post-treatment. Pooled WOMAC physical scores were also statistically significant in favor of PRP at 3 months, 6 months, and 12 months, and pooled Tegner scores at 12 months were statistically in favor of PRP compared to HA. There were no statistical differences observed in the pooled results of all remaining outcomes at all time points. So this is the graphical representation. Incidence of adverse events, really no statistical difference. How about the WOMAC index as time progresses, favoring platelet-rich plasma in this study? What about the visual analog scale? Looks like it is favoring platelet-rich plasma versus hyaluronic acid from 3 months onward up to 12 months. Again, the 5D VAS score favoring PRP, and patient satisfaction, no significant difference. So certainly interesting data that's coming out over the last few years about the role of PRP. What are your thoughts, Tom?
Yeah, I think a lot of patients come in kind of 2 camps. One, they're the new kind of adapters. They think PRP is the solution to all problems, and they are very keen and pursue PRP. And then there's others, probably more commonly, are skeptical of PRP as a new injectable, and based on their previous experiences or talking to others who've had HA injections, they're more willing to entertain that as a injectable. But I must say, based on that evidence, definitely a role for PRP as a injectable.
Yeah, there definitely is a signal out there. I think that's undeniable, and I think where the research really has to focus on is figuring out the optimal preparations, formulations, and indications for PRP. Let's move on to the last ACE report. PRP is superior to hyaluronic acid for symptomatic knee pain at 6 months and 12 months for knee osteoarthritis. This was published in 2020. It was a meta-analysis and systematic review of level 1 and 2 randomized controlled trials. And so what question did they ask? In patients with knee osteoarthritis, how does intra-articular injection of PRP compare to intra-articular injection of HA with regards to clinical outcomes and pain scores? And so large review, more than 1,200 patients, 600 patients in each group, and they looked at various disease-specific index scales and normalized pain scores, and they looked at 2 main time points, 6 months and 12 months. This is a graphical representation of the normalized disease-specific indexes really no significant difference between groups here. You can see the line of estimate of effect, or the confidence intervals, crosses the line of no difference. But when looking at pain scores at 6 months and 12 months, looks to be favoring platelet-rich plasma. Again, there's always risk for bias with these studies, but again, I think the discussion really is, again, the role of PRP may be changing over the last few years with increasing evidence and research towards it.
There's one question from the group. That previous ACE report, number 7, was the HA preparation one preparation, i.e. was it high molecular weight?
Yeah, I'm not sure, actually. That's a very good question. I don't think we have a poll here. Okay, so basically, I think we'll wrap it up now, and we'll just again go over the all available data based on OrthoEvidence's network meta-analysis tool. So again, if you look at the entirety of the evidence, sort of your take-home messages are this line here is no effect. Corticosteroids does result in some favorable effect. High molecular weight formulations of HA, again, do have a favorable effect. It seems to be that combination injections may be efficacious. Extended release cortisones may be efficacious as well. But with regards to PRP, when looking at the entirety of the evidence, there is some concern that our confidence in the estimate of effect really isn't as tight as we'd want it to be. So perhaps PRP is very useful, or perhaps it may not have as much of an effect as we would like to think it does. So just have that in mind when using autologous products, and hopefully that was a helpful review of the evidence. If there are any questions, we can review them now. Otherwise, we'll end the session.
Hello? Hello?
Yep.
Yeah, those studies of PRP versus hyaluronic acid, I think what Dr. Wood said or brought up, or whoever brought up, was it high molecular weight hyaluronic acid? Was it low molecular weight? And they also didn't say if the PRP was platelet rich or platelet poor. So I think, you could take that with a grain of salt. I think you have to point that stuff out, because people are looking at this and you're not giving the full information. And that's the criticism of PRP. There's no good uniform studies with using a set sample of either leukocyte rich or leukocyte poor, and so you have all these studies all over the map. I would not place much faith in those last two studies, 7 and 8.
Yeah, I would completely agree. I mean, if you take the PRP literature as a whole, just based on the various preparations, it's hard to really glean anything. And to your point, probably the next best study would be, given how common leukocyte poor PRP is used, at least in Canada and North America, and compare that to high molecular weight HA would be the obvious study to do with, a big patient population. But I agree with all those points.
Yeah, I agree as well. And that's why, we sort of wanted to really highlight this overall assessment of the entirety of the literature. Because of our confidence in PRP crossing the line of no effect, we can't really recommend it in comparison to all of our other therapies, where we have much more confidence in the effect that it's providing.
I think the gold standard for hyaluronic acid should be high molecular weight, cross-link, long-chain hyaluronic acid. And if it's not high molecular weight, I mean, the study should be done with high molecular weight. All the studies of one hyaluronic acid versus another show that high molecular weight is extremely important. It stays in the joint longer. It has an effect longer for a longer period of time. So any study which has something with a molecular weight of 3 or 2 or something, like Durlane has a high molecular weight of 10. It's the highest high molecular weight of of any hyaluronic acid on the market right now. I think Synvisc is like 7 or something like that, or 6. So, if you don't use the best product and you're doing a study, what use is that study?
Agree. Yeah, agree. I mean, the other thing to consider is a lot of the, at least older studies, were probably sponsored by companies to be done, and I would say the emerging literature and the recent literature on HA has been more focused on high molecular weight for those reasons.
Yeah, I think the evidence really supports